I'm live and I'm live. Hey everyone, howdy, Aaron Boster here, and thank you for joining me for this New Year's Eve live Ask Me Anything Q&A. I've got a lot in front of me. I've got two computers up, and on one of them, hey Tracy Paxton, I'm using YouTube, and on the other one, I'm posting on Facebook. Hey Ken, great to see you. I'm going to attempt my very best to do a simultaneous Q&A right now. Hi, Joy. It's great to see you. Hey, Marcos. How are you doing? Gift Boutique and Cool Black. Great to see you guys. So my goal tonight is to help you rein in the new year. This is a very, very stressful time for a lot of people with MS and without. And sometimes we enjoy, and sometimes we feel a little bit alone and by ourselves. And so I don't want that to happen to anyone this evening. I am going to do my very best to answer your questions live, both on Facebook and on YouTube. And so just a quick shout out to Michael. What's going on, man? Abby Page, great to see you. Candy Duncan, I love you. It's great to see you. Christopher, hello. Going over to the Facebook side, I've got a lot of people joining in. I've got Sharon, how are you? Nancy, Judy, Luann, great to see everybody. This is a lot of fun, and I'm excited to take your questions. Now, a couple ground rules. Ground rule number one, we have to be nice. Sometimes people get really fired up and they say sassy things, and I'm gonna ask you guys, if you don't agree with what we're talking about, please take it elsewhere. Let's not have that muck up what we're doing this evening. And if you who have tuned in see someone who's kind of not being appropriate, go ahead and pause them or ask them to knock it off. I am not going to be able to moderate between two screens, and I'm not very good at this. Number two, I can't answer personal questions. I have to answer generalized questions. So please frame your questions as a general one. I'm not able to diagnose you and provide treatment through the interwebs. I've got folks from Anchorage, Alaska, AK Sonia. I know you're from Anchorage, Alaska. That's awesome. Karen Tweed is online. What's up, Karen? I've got Lindsay here. I've got Suzanne here. I've got Juliet here. And all these people, I'm loving this. So who's going to throw out the very first question? Here we go. Ken asks the question. Ken is going to kick us off tonight. Dr. Ken 2K writes, what do you think of drug Ocrevus? I really like Ocrevus. Now, full disclosure, Ocrevus is an anti-CD20. It's a monoclonal antibody. It's a smart bomb with a very, very specific target. And this is a drug that I was very involved in the phase 3 development, and that I helped run the clinical trials that led to its approval. I have used a lot of Ocrevus. In fact, my center at Ohio Health here in Central Ohio, we were the very first in the world to infuse post-marketing. We've infused over 850 souls with Ocrevus, and I'm a big, big fan of the drug. I work a lot with the company. I've consulted for the company. I've spoken for the company. I believe in the product, and I think Ocrevus is a really solid medicine. It's one of 3 highly effective medicines. You guys have heard me talk about this before. It's my opinion that the 3 monoclonal antibodies, alemtuzumab, codenamed for Lemtrada, Ocrevus, ocrelizumab, and natalizumab, Tysabri, are by far the most effective drugs available by the American FDA. Now, I have a couple props. We're having pizza tonight, and my son showed me that you can pop out a mustache on the box, so I promised him that I'd wear it. And that's what I think about Ocrevus. Now, let's take another question. I'm going to try my best to go back and forth, a question from YouTube, a question from Facebook. So wish me luck. So Allison writes in, my first full dose Ocre infusion is in a few days. Allison, you rock. You're going to do great. If I take another question over here, so MS Memes writes, thank you for taking time on New Year's to talk to the folks with MS. My question, before I forget it, was how to deal with fatigue and heat, and why does it wipe many of us out, even taking a shower? So MS Memes and more, MS Information, howdy. Thank you for joining me tonight. And that is an outstanding question. I want to unpack it. So the first thing is, many of you have heard the joke, which is not a funny joke. You've heard the joke, you know it's MS when you have to take a nap after a shower. And people that aren't familiar with multiple sclerosis giggle and they think that's funny. People that understand MS know there's nothing funny about that because it's actually true. And the reason is when we take a shower, we tend to take a warm shower, or at least I like to take a warm shower, and it heats up our core body temperature. And when you heat up the core body temperature, and I'm talking like 1 degree internally, like just a little bit, it can cause a damaged brain and spinal cord to literally short circuit. And the way I like to think about it, think about your extension cord. All right. So you've got that orange extension cord that you have with all your Christmas lights, and you keep it in the garage. And once a year you get it out and you put it outside. And maybe your spouse by accident ran it over with their SUV and they cut the cord or crushed the cord. Now they didn't rip it in half, they just beat it up. And so you do what any red-blooded American would do. You duct tape the hay out of it and you think, oh, it's pretty good. So you now have an extension cord that does not work at 100%. It only works at say like 90 or 95%. And when you plug in 2 Christmas lights, it's gorgeous. When you plug in 5 Christmas lights, it's okay. When you plug in all 10 of your Christmas lights, the darn thing short circuits. It doesn't work. It can't handle the full capacity load. And so when you unplug 8 of those Christmas lights, it works back again. And the cord analogy that I'm using, that spinal cord is like the electrical cord. Your brain in many ways is like that electrical cord. And if you overload the circuit, and in a human model, overloading the circuit means heating up the core body temperature, you can literally short circuit. And heat sensitivity affects different people in different ways, and it has everything to do with where the lesions are in your brain and spinal cord. But many, many people have a worsening of pathologic fatigue. They can have motor fatigue, and it's a really major issue. It's also a silent symptom. It's one of those things where to look at someone, honey, you look so good, it looks like there's nothing wrong with you. I saw a great shirt. It said, I don't look sick. Well, you don't look stupid. And I'm not calling other people stupid. I think it's a hilarious shirt. And I think it speaks to the fact that there is an invisible nature to this disease. And the more that we understand that, I think the better we can do at combating that. That's a fantastic question, and I thank you for that. And so now I'm going to jump over on the Facebook side and try to answer some questions over here. And Jill Moberger writes in and says, can you talk about Botox and spasticity of the legs? Yes, I can. I most certainly would be happy to talk about spasticity. Spasticity is a problem which is very, very common in MS. About 70% of people with MS can develop spasticity of varying degrees. Woo! I'm getting overheated here. And so when you have spasticity, it's really a problem with the muscles not communicating. So if you look at this massive bicep of mine, and I want to bring my bicep all the way here, or better yet, I want to bring my New Year's grog to my mouth. I don't say bicep contract, tricep relax. No, I say beer. And the tricep relaxes while the bicep contracts. My brain and spinal cord do that for me. I don't have to coordinate that. And in the setting of damage to the brain and spinal cord for multiple sclerosis, that message can get goofed up. So when you want to bring your bicep in, you also want to extend your tricep. And the reality is you get a tug of war with your own body where your muscles are pulling this way and that way. And the way that that manifests clinically is 3 ways. Number 1, stiff limbs that are hard to bend. And many of you know exactly what I'm talking about when you try to get in the car and you swing your leg and you got to bend it to get in the door and you can't. Or you stand up from a chair after sitting too long and you can't get your legs to unlock. The second way that spasticity presents is with spasms. And a spasm is a bouncing. And then also the third one is a cramp. And a cramp is a painful contraction of the muscle belly like a Charlie horse. And so these are very, very common ways that people can present with spasticity. Now, the question was, what about Botox? And so Botox is a toxin. It's actually one of the most toxic substances in the world. And too much Botox can kill you. But a little tiny bit of Botox injected into the muscle, a little tiny bit, it can make the muscle so it can't fully contract. And what that allows you to do is it lets the bicep contract and it allows the tricep to relax. And so Botox is amazing for focal spasticity. If both your legs are stiff, you can't Botox both your legs. There's too much legs and not enough Botox. But if just your foot is spastic or just your hand is spastic, you can Botox and pop it open. Now, I don't do Botox. One of my partners, Dr. Jacqueline Nicholas, who is one of the most amazing MS doctors I've ever worked with, is a grand wizard at Botox. Candy Duncan writes in, can Botox help with headaches? And the answer is yes, yes, yes. Botox can help with headaches. So that was a wonderful question from the Facebook side. Thank you very, very much. Let's turn over to the YouTube side. And by the way, I've already spoiled what's in my New Year's grog. But I'll tell you what, I want to ask you guys, which beer do you think this is? Put in the comments what kind of beer you think I have in here, and I'll tell you if you're right or not. Looking over here at the YouTube side of things, I've got a question from Terry B. Terry, how are you? It's great to see you tonight. She writes in, do you treat people diagnosed with, and if so, what do you treat? Do you treat with MS therapies? So yes, Terry, I am a neuroimmunologist. I'm a neuroimmunologist, which means I really deal with the interface between the nervous system and the immune system. All right. And so that interface most commonly presents with multiple sclerosis. But we deal with any central nervous system neuroinflammatory condition. And NMO, neuromyelitis optica, is most certainly one of those conditions that I manage. And so we have several people. We probably have close to 100 folks in total that we care for at the Ohio Health MS Center with NMO, neuromyelitis optica. And the medicines that we use are not always the same. It turns out that using interferon beta medicines, this is like Avonex and Rebif and Extavia and Betaseron, for NMO actually makes NMO worse. And so you don't want to use those medicines for that. We learned that the hard way. We use anti-CD20s. So that medicine I talked about, Ocrevus, there's an older medicine which is very similar to Ocrevus called rituximab. And it's the drug of choice when trying to treat NMO. So that was an outstanding question. Thank you for it. I have a lot of people guessing what kind of beer I have in here in my grog cup, and none of you have hit it yet that I've seen. And so we're going to leave it out there. Now, going over to the Facebook side of things, I want to grab a question over here. And so let's take a look. Stephanie Kovitz says, Happy New Year's. Well, Happy New Year's to you and to your family and your beautiful children and your wonderful husband. And here's a question. So Beverly Smith Deskin writes, best advice for families and loved ones of an MS patient. And I love that question. And many of you know I was a family member growing up in a home with MS long before I was a doctor managing MS. And so what's the best way that you can support someone? What's the best way that you can be a valuable village member? First of all, you need to believe someone when they tell you they're tired. You need to believe someone when they tell you you're vertiginous. You need to believe someone when they tell you that they're depressed or that they have burning in their leg that you can't see. It is infinitely frustrating for people with MS to look so good, and yet inside they're struggling. And so you can be a loving, supportive, and helpful person simply by believing them when they tell you something. People aren't making stuff up. No one wants to feel this way. And that's a really great way. And one of the things that you can also do is tell someone that you're there for them in a way they want to be there. Sometimes when you invite someone out to lunch, you think that's a very, very nice gesture. Well, if you have MS and you have a very small functional reserve, going to lunch might take up all the spoons you have for the day, and you may be completely destroyed afterwards. And so a friend, a loved one of someone with MS has to understand when they say, I can't make it out today, it's not because they don't like you. It's because they're struggling. And it's reasonable to ask, could I stop over? Things like that. Now, there's a bunch of other things that we can do, but those are things that I want to leave you with. The sensitivity that just because it's invisible doesn't mean it's real. And asking someone how best to interact. And if you tell me you're having a tired day, well, let's scrap our plans to go to the zoo. Maybe we'll just hang out and chit chat. Now, going back over here, Sarah writes in, she says, I don't feel tired during the day, but at night I don't wake up when my kids cry. My poor husband has to get up all the time. And is this fatigue? Now, not necessarily. So she's describing a situation where she sleeps like the dead at night. And that can be innumerate things. It's not generally something associated with MS. And so I'm going to let that one ride, but thank you very, very much for the question. Now, the Laney writes in, is hair loss normal in MS? Now, hair loss is very normal amongst MS doctors. In fact, hair loss is extremely normal amongst some MS doctors. Hair loss is not normal with multiple sclerosis. Now, there is a medication called teriflutamide or Aubagio. And Aubagio rarely, in about 13% of patients, has a transient hair loss. And it's not a hair loss like this, it's just thinning. It starts at about 2 months and it goes away about 6 months. And if you stop the medicine or if you don't stop the medicine, it will still occur and then come back. And so you don't need to stop the medicine. But that's one that we can see. Now, there are other autoimmune conditions that can lead to hair loss, things like lupus and other conditions. There's even a autoimmune alopecia, but MS typically does not do that. And that was a great question, and thank you for that. And so I'll give you guys a hint to the beer and the grog. And so if you can identify this can, that might help you as you try to identify what exactly is in here. All right, so moving over to another question, and I am really, really enjoying these questions tonight. You guys are fantastic. Amy Jo Ferguson writes in, hello, Amy Jo Ferguson, I hope you're doing well. And she says, what do you think of Gilenya? Well, I like Gilenya. I think Gilenya is a really, really good drug. I personally think Gilenya is probably the 4th best drug available in the MS armamentarium. That's right, Shells Z, you nailed it. This is Stella Artois. I have Stella in my cup. Back to Gilenya. Gilenya is a pill that you take once a day for MS. It was FDA approved in October of 2010, and there's been a bunch of people worldwide that have been on it. It's a very easy drug to tolerate, and it's a simple drug. You take it once a day. And I think that it's a highly effective therapy. My opinion is that it's not as effective as the monoclonal antibodies. So it's not as effective as Tysabri, Ocrevus, and Lemtrada. That's my opinion. But I think it's probably the most effective of all the pills. As far as efficacy goes, it's my opinion that I rank Gilenya, fingolimod, over Tecfidera and Aubagio from an efficacy standpoint. Now, Gilenya is not for everybody, but many of my patients, particularly my young patients, thrive taking Gilenya. It's good stuff. And that was a great question, and I thank you for that. And so now turning over to the YouTube side, and Elijah writes, I have trigeminal neuralgia, and it is annoying to say the very least. Understatement of the year. And I keep having to up my medicine because it's getting worse. Any suggestions? Now, Elijah, I can't comment on your trigeminal neuralgia, but I want to talk about trigeminal neuralgia in general. There are nerves that run the entire face, and there's nerves that run the sensation, so like I can feel when I'm being touched here. There are times when one of those nerves that provides sensation to either the top, the middle, or the bottom part of the face can become irritated, and it can send essentially a painful electric shock. Now, this is described as one of the most painful conditions in the human experience. In French, it's called tic de roue, and it can lead to suicide because it hurts so damn bad. And so we take this very, very seriously. Now, people can get trigeminal neuralgia because the nerve that comes out of the skull, actually, I've got this skull here, and you'll notice that there are some holes where you can see that a nerve would come out. And so they come out through the bone, and if where the nerve comes out, it gets smushed, it gets crushed, it can crush that nerve and cause a problem. But in MS, there's yet another way that you can develop difficulties with trigeminal neuralgia. Because in MS, you can affect the brain center of that nerve. Essentially, the nucleus of that nerve can be affected in MS. And it can be very, very challenging to treat. Hey, what's up, Russell Hall? Great to see you. Happy New Year's to you, my friend. And so what do we do to treat trigeminal neuralgia? It is challenging to treat trigeminal neuralgia. And we use seizure medicines. Why do we use seizure medicines? Because seizure medicines stabilize cell membranes. That's how they stop seizures in the brain. But they also stabilize cell membranes in the nerve. And so they can quiet down this ephaptic discharge, this painful discharge. The drug of choice is an old one called carbamazepine or Tegretol, but there's innumerate drugs. And oftentimes we have to use not one, not two, but 3 of these anti-seizure drugs to control the discomfort. There are procedures, surgical procedures that can be done. And one of the ones that we've had the most success with is with gamma knife. Now, gamma knife sounds cool, and it is cool, and it's really using like a gamma radiation and zapping it. And this isn't foolproof, and sometimes the pain can come back, but when it works, it's really, really wonderful. That was an awesome question. Thank you for that question. Now, coming over here to the Facebook side of things. I've got a bunch of people writing in, and let me find a question here. How effective is Mavenclad? This is my first DMT. So somebody asks about Mavenclad. Lisa does. Now, Mavenclad is a brand name for cladribine. Cladribine was intended to be the very first pill approved for MS back in 2009, 2010. And the FDA refused to file. So they basically said no. And that was really sad. And I remember when that happened, and I sort of just got rid of all the information about cladribine out of my head because it wasn't going to be FDA approved. And now many, many years have gone by. 8 years have gone by. And they've scrapped together a long-term follow-up cohort, which wasn't done scientifically very well, but it was done. And the European governing bodies, the EMA, approved it. So it's now approved in several countries in Europe. It's also approved in Canada. Now, the question for a lot of Americans is, will it be approved here? And my guess is that it will be approved here. Mavenclad cladribine is a microinduction therapy, which is absolutely fascinating. What you do is you take 5 pills, a pill a day for 5 days, and then you don't do anything for a month. So it's kind of like a reverse birth control pill. 5 days on, a month off. Then you do that a second month. You do 5 days on, then a month off. Then you're done being treated for a year or so, maybe even 2 years. And so it's an exciting medicine in that it's microinduction. When I look at the clinical trials data, I think that the efficacy is a lot like Gilenya. That's my opinion. And there may be people out there that disagree with me, but they're not online live, and so they don't get to share their opinion, but I do. And that was a great question, and I thank you for asking it. Now, turning over to the YouTube side, let me see what I got here. I thought cladribine was originally used for leukemia. You're right, Darla. And in fact, many of the MS medicines were originally used for other reasons, right? So very few medicines were actually invented to treat MS. So if we kind of list through the medicines, Copaxone was developed to treat MS. It was discovered in the mouse model of MS, trying to make the mouse model worse, and it made it better. And they were like, ooh. Interferon medicines. Interferon medicines have been around for a while, and they're used to prevent viral replication. And when you inject them into yourself, the reason that you feel like you have the flu is the interferons that your body makes you feel like they have the flu. But they weren't originally invented for multiple sclerosis. Tysabri was a medicine that was actually invented for MS. Ocrevus was originally tried in a different autoimmune disease before it moved into MS. Lemtrada was originally tried in a form of cancer. So my point here is how we come to these medicines is fascinating. And not every medicine do we start off using MS. Sometimes we find, oh, wait, this would work in MS, and we shift gears. Great question. Now, over here, Michelle writes, MD3001, which is high-dose biotin. Biotin, which is a B vitamin, is in phase 3. Seems promising. What are your thoughts? Of course, if you are not a study physician, you might not be able to say, well, I am a study physician. And I also use off-label high-dose biotin. So I was struck, really struck by the impressive data that we saw over the last couple of years about high-dose biotin. Now, when you get biotin at Kroger's or at some pharmacy at 3 milligrams, it's supposed to improve the quality of your nails and your hair. Very clearly, I'm not taking any biotin. But when you take 300 milligrams, not 3, but 300 milligrams, in PPMS, we saw some impressive stuff. We saw that in primary progressive MS, it slowed disability. Biotin, B7, it's a vitamin, slowed disability in primary progressive MS, which is insanely cool. We also saw in a different trial that biotin slowed brain shrinkage in PPMS. Those are extremely impressive results. Now, there's one very important caveat with biotin. So I need you guys to listen to me, and to show you how serious I am, I'm going to go ahead and put back on my entire getup as I tell you about this important thing with biotin. Biotin can literally change the results of certain lab tests, and specifically thyroid tests, when you're looking at hepatitis panels, when you're looking at cardiovascular tests like for heart attack and stuff. Biotin can give you a false positive. And so in order to prevent having a false positive test, now you don't have something wrong with your thyroid, for example, just the test comes back abnormal because the biotin affects the test. You have to let the biotin clear your system prior to having your labs drawn. Now, there's a paper that was recently put out that suggested you just need 2 days off biotin because you clear it very quickly. I ask my patients that are taking high-dose biotin, 300 milligrams a day, to take 5 to 7 days off just to make sure it's completely out of their system prior to getting a lab done. So my take-home here is early research in biotin rocked my mind. It was awesome. And I actually will put people on biotin if I'm concerned about their brain volume, if I'm concerned about progression. But we have to stop it a couple days before a lab test. Otherwise, we risk having problems with fake results. Now, Laney writes, thoughts on medical marijuana. And I'm amazed that we're a full 22 minutes into this MS Ask Me Anything. And it's the first time I've been asked about ganja. I've been asked about cannabis. And so let me share with you some thoughts about medical marijuana and cannabis. And I want to share with you the 3 things that we know to be true from science. Thing number 1 is that cannabis seems to help spasticity in multiple sclerosis. People that have MS with severe spasticity, with moderate spasticity, sometimes find that using cannabis products helps with their spasticity. Anecdotally, I absolutely have had innumerable patients tell me, Doc, if I use this substance, my spasticity is manageable, I can go to bed. And you know what? I believe them. Now, the second thing that we've learned from science about cannabis in MS is that it can help with neuropathic pain. So cannabis can be very, very effective in treating MS-associated neuropathic pain. And that's true. And again, anecdotally, I can share with you that I absolutely hear that all the time from patients. And I think it's true. The third thing that we've learned from science as it relates to cannabis is that it can destroy cognition. It can worsen cognition. Now, there was a very provocative study where they took people with MS and they did a cognitive test. And they grouped them into, you have cognitive problems and you don't have cognitive problems. So 2 groups of people with MS, some with cognition and some with problems with cognition, right? 2 different groups. And they had them smoke a joint, like smoke a joint of marijuana. And then they sent them home and they had them come back 2 weeks later, 2 weeks after using cannabis. And they did more neuropsychometric testing, more cognitive testing. Now, the people with MS that didn't have cognitive problems performed worse on their cognitive testing after 1 joint 2 weeks later. But the people that were cognitively impaired with MS plummeted. They plummeted in their cognitive deficits only after 2 weeks. Now, I'm not trying to be gloomy and doomy, but I am pointing out that one of the major problems with MS is problems with cognition. So difficulty with thinking and memory is one of the leading causes of loss of work in MS. It's one of the most common symptoms, and it's one of the most evil symptoms. And the fact that cannabis could interfere with cognition is a really big concern of mine. Now, I one time had a young man come in my office, and we were talking about medical marijuana because lots of people want to talk about that. And he said, Dr. Boster, do lots of patients tell you that marijuana helps their MS symptoms? And I said, yeah, they do. And he said, can I be honest with you? I just like to get high. And you know what? I really appreciated his honesty. I thought that was pretty awesome. All right, so moving on to other questions. Jody Thomas writes in, hey, Jody. And she says, Happy New Year, Dr. B. Happy New Year to you too. And she writes, what is your best DMD suggestion for RRMS or active SPMS suggestion? I was dosed in 1994, and I was on Copaxone, currently on Tecfidera. All right, so let's talk about this misconception of relapsing remitting MS and secondary progressive MS, as if you go along and you have relapsing remitting and bam, now you have secondary progressive MS. Well, guess what? That's make-believe. It doesn't really work like that. The reality is that there is a pro-inflammatory part of this disease that can cause attacks, it can cause new spots, and as we age, our chronologic age, the risk of having acute bouts of inflammation, attacks, and spots decreases. So statistically, you are less likely to have an attack at age 60 than you are at age 30. That's true. Now, MS is a progressive condition. It is. And in fact, if you look at the very earliestly diagnosed patients, clinically isolated syndrome, you can demonstrate that they're starting to have some progression if you use very, very sensitive testing. And so in reality, I do not feel like there's a clear-cut, this is relapsing MS and this is secondary progressive. Because people with secondary progressive MS are people that have had attacks. and they are at risk of having attacks. They're less likely to have an attack as they age, but they're also less likely to bounce back. And so I don't find it useful to create this delineation of, oh, you have secondary progressive MS, so there's nothing we can do for you. That's BS. That, my friends, is not true. Moreover, many of the DMTs, particularly the newer disease-modifying therapies, have been shown to impact progression. And so I think it is nonsensical to take someone off of a medicine because they've achieved this make-believe vantage point of secondary progressive MS. That's hogwash. It's hogwash. And we want to continue to treat. We want to continue to provide anti-inflammation to diminish the risk of having a new attack, to diminish the risk of new spots, which is brain damage. That's brain damage. And we want to do everything we can to fight against progression. And so I want people on a disease-modifying therapy. Now, you might say, well, which is the best one? And that gets very, very complicated. I think that the best one for person A might be different than the best one for person B. I'm going to leave it at that, and we can jump in and talk a little bit later. Stuart Schlossman is online. Stu, what's up, my friend? It's great to see you here. And Stuart reminds us that on March 2nd, we are doing something awesome sauce here in Columbus, Ohio. So for those of you that are in the Midwest, I want you to make a road trip to come and visit us in Central Ohio and Columbus, Ohio on March 2nd of this year, March 2nd, because Stuart with MS Views and News and my group at Ohio Health MS Center are banding together to rock it out and put out an amazing patient program. It's going to be colossal. We're going to have 6 or 8 MS specialists of all kinds of different ilks. We're going to have pelvic floor physical therapists, and we're going to have neurourologists, and we're going to have guys like me. I'm going to be talking about cannabis, actually. And it's going to be really, really special. And it's going to be broadcast. You're going to be able to watch it on the interwebs. And it's going to be something very, very exciting. So you guys on Facebook, if you could give a thumbs up or a heart, if you feel the love for what Stuart and I are going to be doing. And all of you on YouTube, let's keep in mind that we are going to be bringing live education March 2nd to Columbus, Ohio. Now, JJ Cooper, what's up, my man? He writes, I was in MS limbo for years because I saw just neurologist. They say I had RIS, radiographically isolated syndrome. Is that now treated? I did move to RMS a year later. So let's unpack that question. By the way, JJ, it's great to see you. Thank you for joining us tonight. So JJ talks about RIS. RIS stands for radiologically isolated syndrome. And here's the deal. When you have multiple sclerosis and you're diagnosed with a clinical event and we get the first MRI, very commonly, we don't see one spot, we see multiple spots. Each one of those spots represents a period in time when you had an attack. It didn't manifest clinically, but there's a mark on your brain scan that tells us that there was an acute bout of inflammation at that point in time. And yet the human being might not have had symptoms. And it stands to reason that if we start to go around and MRI everybody, and we MRI almost everybody, if you come to my hospital and you tell them that you have a headache, you're getting an MRI. We discover incidentally that some people have MRIs of their brain that look like MS. The brain scan meets criteria for MS, but the patient has never had an MS symptom. They've never had an attack. And when you examine them, there's nothing on exam to suggest MS. And so what is this? Well, it's probably on the spectrum of multiple sclerosis. And when we study people with RIS for 10 years, we find that about 1/3 go on to have clinically isolated syndrome and multiple sclerosis, the way that JJ Cooper described. Now, in my clinic, when I see RIS, which is not that often, I treat it. I put people on medicines like glutaramine acetate, which is very, very safe. Because I want to give them every fighting chance. Now, my contention is, look, if we go 10 years and you don't have MS, I'll apologize to you. But if you develop MS and we've got a head start on treatment, I really think that's worth its weight in gold. And so RIS is very, very important. There is a clinical trial out of UT Southwestern. A good friend of mine, Darren Akuta, who is one of the best MS doctors in the universe, is running a trial looking at RIS in Tecfidera. And it's a really, really cool trial where he's trying to determine whether or not early treatment helps out. My opinion is it probably does. So moving on to other questions, let's take a look here. And I've got Stephanie Clark-Kovitz that writes in, would you put someone on Lemtrada as their first DMD? So she's asking, would you use Lemtrada first line? Now, just to give you some backstory, in the clinical trials, we did 2 clinical trials. The first one was called CARE-MS-1, and the second was called CARE-MS-2. CARE-MS-1 and CARE-MS-2 were the same design. People in the trial either took Rebif or Lemtrada. The difference was CARE-MS-1 were treatment naive. They had never been treated before. This was their first time being on a therapy. CARE-MS-2, these patients had at least been on one drug that failed them. And so we learned that it works, Lemtrada, both in first-line use, CARE-MS-1, and in second-line use, CARE-MS-2. When the drug was approved in Australia, it was approved first-line. When it was approved in Europe, it's approved first-line for aggressive MS. In Canada, it's approved second-line. And here in the United States of America, gosh darn it, they approved it third-line because of concerns of safety. Now, I really am bothered by that because the drug works better the earlier you use it. That's true. I had an honor of sharing a stage with Alistair Coles. Dr. Coles is a world-renowned neuroimmunologist and MS specialist out of Cambridge in England, and he helped develop Lemtrada. And I got to share a stage with him. I was talking about Lemtrada use in the United States, and he was representing Europe. And I shared a story, which was kind of a really cool story about someone that regained function. And so this person had really bad MS and had been on lots of stuff and it didn't work. And we put them on Lemtrada and it rocked. And that was awesome. And when I was done telling that story, he turned to me, and I can't do an English accent, so I'm not going to try. And he says, "That's a very wonderful story, young man, but that is not why we invented Lemtrada." He said, "We invented Lemtrada for a young Caucasian woman after her second attack." And he's right. If I could use Lemtrada first line, I would like to, because it works better the earlier you use it. Now, I'm not allowed to do that. The FDA disallows that, and that's very sad. And it's my hope that maybe in the future, the FDA will wise up and realize that allowing us to treat MS earlier results in a better outcome, which is really the goal here. So we've reached the half an hour mark, and I want to keep going. So I hope you guys want to keep going. So if that sounds good, let's keep on keeping on. And I'll highlight that with a sip of my grog. And we'll jump into yet another question. So Sarah writes, "What about genetics? My mom, myself, and my brother all have MS. My parental auntie also has MS. There has to be a genetic link. Can you explain that?" I can try to explain that. Now, MS is not considered a classic genetic condition. There are certain genetic conditions like cystic fibrosis, where if you have cystic fibrosis, up to 1 in 4 of your kids is going to have cystic fibrosis, and the other kids are going to be carriers. And that is a very classic Mendelian genetic condition. And MS is not like that. In the Midwest, there's a lot of multiple sclerosis where I come from. And the average incidence of multiple sclerosis in the Midwest is 1 in 700. If you have MS, your first-degree relatives, so your mom, dad, brother, sister, kid, have a risk of somewhere between 1 and 3 in 100. So up to 3 in 100, or down as low as 1 in 100. And that's way more than 1 in 700. And so for most families, that's the risk profile. And by the way, we think that we can lower the risk in children by avoiding smoking and secondhand smoke, avoiding morbid obesity. These are things that look like they slow MS, and in increasing children's vitamin D3 seems to have an effect. I am not telling you to give your kids D3. I am telling you that if you have MS, you should ask your kid's pediatrician to check their D3, their vitamin D, and see if it's low. And if it's low, you might want to supplement. Now, there are less than 10% of situations where we see families that cluster, like you're describing, where you have you and your mom and your sister and your brother and your auntie. And that's not very common. The reality is we do not fully understand this condition. And maybe you get to the diagnosis of MS through multiple different means. And maybe there's a flavor that is autoimmune, autosomal dominant. Maybe there's a flavor that's not, and we don't know yet. But traditionally speaking, this is not considered a classic genetic condition. That was a great question, and thank you. So Jesus Christus writes, someone can write German. And so I can't write German. Ein Bier bitte, super guja is about the extent of my German, which really works very well in a lot of German pubs. And so moving over here to the YouTube side. Mindy writes in, and Mindy writes, my neuro didn't switch my diagnosis because insurance would kick me off Tysabri. So what Mindy is talking about is that there are certain insurance plans where if you have a certain kind of diagnosis, then they don't want to approve it. And I think we see this less than we used to. It used to be when I was in my fellowship training that if you said someone had secondary progressive MS, the insurance company stopped the therapy. Similarly, if you said someone had PPMS, the insurance company stopped the therapy. And that's awful. And it led many doctors to just describe that someone had MS and just treat MS. And scientifically, honestly, that's probably smart. Because I think one of the things that we've learned through Ocrevus, which is approved in America for PPMS, is that we need to treat inflammation in people with primary progressive MS in the same way that we have to treat people for inflammation with relapsing MS. And Lisa writes, can you see a cure? So Lisa asks the question, which I'm very, very commonly asked, can you see a cure? And Lisa, from my heart, in my life, no. From my heart, I don't think that we're going to see a cure by the time I pass away. I'm not saying that to be crappy or gloomy and doomy, but it's true. Our understanding of neuroimmunology is ever growing, and we're not there yet. We still don't fully understand what causes the disease. We fully don't understand all the cells involved. Every year, there's new revelations. Just last year, we learned that the brain has a lymphatic system. We didn't know that. We're learning that microglia and astrocytes are very actively involved in MS. We've only recently appreciated that B cells are involved in MS. We've only recently remembered that gray matter is involved in MS. My point here is I don't think we're there yet. Now, I said this last night, and I'm going to say it again tonight. What I do think is reasonable is to make MS boring. Boring is a high compliment. I want you to have excitement in the bedroom. I want you to have excitement in the playing field. I want you to have excitement in the boardroom. I want clinic to be boring because boring is a high compliment. When we're talking about my dog and my kids and your vacations and what's going on, that means we're not talking about loss of function. We're not talking about the fact that you're blind in one eye, God forbid, or the fact that you can't feel your leg. And so I think that it is reasonable to make this disease boring. And even in 2019, we, in some patients, can achieve boring. And that's awesome. It's really, really awesome. I tell my patients, it's my goal that you don't believe me. If I do a good job, you're going to think you don't have MS, which is really what I want to try to have. And so when you tell me, well, I don't think I have it, I think that's fantastic because it speaks to me about how well you're doing. So jumping over to the YouTube side, I've got a question from Divine, and I think that's Cynthia. And how you doing? Let's see. No, she's not writing to me. She's writing to someone else. But she wrote, look up 4 for 4. And so she's using some of my verbiage. And so I'm going to talk about being 4 for 4. I have a cutesy saying that I want you to be 4 for 4 in your fight against MS. And so at home watching this, say it with me. I want you to be 4 for 4 in your fight against MS. And what do I mean by that? I mean that there are 4 things that I want you to do all the time to combat your MS. Number 1 is get on a disease-modifying therapy and make sure it's working. Now, how do you make sure it's working? Well, you get MRIs to make sure there are no new spots, and you see your neurologist so they can examine you and make sure they don't see new deficits, and they listen for attacks and loss of function. And if you're not having that, the medicine's working. And if you are having that, you need to switch. That's number 1 in being 4 for 4 in your fight against MS. Number 2 is to exercise as part of your lifestyle. Science has taught us that people with MS that exercise routinely as part of their lifestyle have a slower progression of disability compared to those that don't. Now think about that. If you're in shape, you fare better than if you're not. I could talk about that for a year and a half, but I want to keep moving on with being 4 for 4 in your fight against MS. Number 3 is to not smoke cigarettes. Smoking tobacco speeds up MS almost by 50%, according to some trials. That's a really, really big deal. That is a larger increase in disease activity than some of the disease-modifying therapies can lower. So you might have more impact by not smoking cigarettes than you do by taking a DMT. And so I want you to do both. So take a DMT, make sure it's working. Exercise is part of your lifestyle. Don't smoke cigarettes. And supplement low levels of vitamin D. So this is being 4 for 4. And if you are learning about MS, if you're trying to beat the crap out of MS, if you're trying to survive and thrive despite having MS, you better be 4 for 4 in your fight. I want that. Now, Mike writes in, cigarettes is a tough one for me. And Mike, I respect that. Quitting tobacco is hard. It is one of the most addictive substances on earth. And I learned something in med school. I learned in med school that it's harder to quit tobacco, nicotine, than it is to quit heroin. And I thought that was really weird. And so I have a couple patients who have MS that have survived heroin addiction. And some of them smoke cigarettes. And so I asked a nice lady, I say, hey, I learned this thing in med school. Is it true? She said, Aaron, it's 100% true. She says, I've been clean and sober from heroin for 5 years and I can't quit smoking. So it's not an easy breezy cover girl thing. And yet it is really, really important. Now, coming over here, I've got another question from Randolph. And Randolph says, your thoughts on an autoimmune diet like the Terry Wahls diet? All right. In order to answer that question, I have to take a sip of grog. There is no diet that has been proven to slow MS progression. Hear my words. There is no diet that has been proven to slow MS progression. Not yet. Now, that doesn't mean that we can't improve our health by dieting. That doesn't mean that we shouldn't pay attention to what we eat, because we should. And in fact, the diet from Terry Wahls is currently being studied in research to see if it might improve fatigue. And it might improve fatigue. I have a problem with Terry Wahls. My problem with Terry Wahls is that she did something which I think is reprehensible. She has MS and she changed her diet and she felt better and she wrote a book. Now that's cool if she wrote a book. I think that's wonderful. But she said in her book that she cured MS with the diet. She cured her MS. And Terry Wahls is a doctor. Now, in the United States, in our culture, when you use the initials MD after your name, that means some stuff in our culture. That means that you are medically savvy and that what you're saying comes with authority. And so when you write a book and say, I'm a doctor, I cured my MS with a diet, you create arguably one of the worst things that you could ever create. False hope. And I'm not okay with that. Now, if Terry Wahls wants to write a book and say, hey, I didn't test this scientifically, but I think that my diet's really cool and I took it and it makes me feel a lot better, I think that's awesome. And in fact, her diet is a modified paleo diet. I eat a modified paleo diet because I feel better when I do it. And you might feel better when you do it. And if you do, I think that's awesome. But I do not want you to think that it slows progression of MS, because we haven't proven that. And what breaks my heart is I have some patients that come to me and say, Dr. Boster, guess what? I'm stopping my medicine. I'm not going to use my medicine any longer because I'm just going to do this diet. And that's not okay with me. And so if you are taking a disease-modifying therapy and you're exercising and you're not smoking and you're supplementing your vitamin D and you want to do some diet, okay, that's cool. I'll give you an example. I love my mother. My mother's an awesome woman. She's really, really cool. And she likes to eat gluten-free. Now, she does not have celiac sprue. She does not have a gluten allergy, which would preclude her from eating gluten. But when she avoids gluten, she feels better. She has more energy. And so God bless my mother. And if she wants to not eat gluten because it makes her have more energy, I think that's wonderful. And I think the same thing for you. I am not trying to tell you that diets are dumb, because they're not dumb. I'm not trying to tell you that it doesn't matter what you eat, because it does matter what you eat. I'm trying to tell you that there's no science that proves that a diet slows multiple sclerosis. It might help with symptoms. And if you're curious about it, I want you to try it. Not necessarily the Wahls diet, but I want you to try a diet and see what you think. My recommendation for the very best diet is a heart-healthy diet, because cardiovascular risk factors like smoking or high cholesterol or hypertension or diabetes, they can make MS run faster, meaning people with MS that have comorbid cardiovascular conditions get worse faster. And so if you can control those things by not smoking, by lowering your cholesterol, by lowering your blood pressure, by managing your diabetes, you actually have a slower disease progression. Now, we have 15 minutes left, and I am going to challenge you I am going to challenge you for the new year. I am not going to challenge you to come up with some series of things that you're going to try to do. I'm going to go to the gym 5 times a day, and I'm going to climb Mount Everest, and I'm going to do all these things. Because when you make New Year's resolutions like that, they typically last about 3 weeks. That's not what I'm looking for. And so I'm not going to ask you to make a New Year's resolution. I am going to recommend that you identify a word of the year. A word of the year which is going to guide you through the year. And so I'm going to pick the word family. That's going to be my word of the year, is family. And I want to keep in the forefront of my mind my family. I spend a lot of time at work. I spend a lot of time interacting with people with MS and helping the MS community. And I want to make sure that I don't forget about my loved ones at home. And so that's going to be my word of the year. And I want to know what your word of the year is. And so in the comments, write down your word of the year. Is it happy? Is it energy? Is it health? Resilience. Delaney writes resilience, and that is a baller word of the year. I like Laney's word. Here, Laney, resilience. That's an awesome term. So moving over to the Facebook side of things, Aaron McCann writes, I watched another of his videos earlier today, so I assume I'm him. And he said no, but the disease will become boring like disease monitoring. So Aaron's talking about something that I said with regards to an MS cure. So Ellen writes in, her word of the year is positive. Darla's word of the year is love. Sherry's word of the year is hope. I think these are awesome. Karen writes her word of the year is balance. And Colleen writes that it's peace. Sarah writes calm. I like that. Calm is a great word of the year. John Wayne says stress-free. And I would love that. I don't know how to do that, but it's pretty awesome. April says allowing myself to cry. And I think that's fantastic. Now, April, you may know I recently put out a video talking about celebrating victories and grieving losses. And I think it's okay to cry too. I think sometimes we have to be sad and we have to accept that things aren't the way that we want them to be, and then we need to move on. Now, there's a lot of other words: productivity, strength, improve. Here's a great word: pizza. I love pizza. So Lattice writes her word is whole. I've got strength, fulfillment, encouraging, socialization, self-control, positivity, activity, research, sleep. AJ's HR writes sleep. And you know what? That's an awesome goal. Keeping in mind the word of the year being sleep can help us. Bacon. Mike writes bacon. Bacon is the very best condiment in the universe. Recently, there was some scientific papers that suggested that bacon has a risk for cardiovascular disease like smoking. And that made me immensely sad because I really like bacon a lot. Now, looking over here at some of the remaining questions. Andrea Martin writes, are you taking new patients? Laugh out loud. Well, I'm not laughing. Yes, I'm taking new patients. So at Ohio Health, we see 18 to 20 new patients a week. We have several fellowship-trained neuroimmunologists. We have people that have been doing this for over 25 years. We have a team that we're very proud of, and we will always take new patients. We will never stop taking new patients. Why? Because it's our goal to beat the crap out of this disease, and we want to make the disease boring with you, and we want to be village members in your fight against MS. So yeah, we definitely take new patients. There's a lot of really cool words of the year coming on. And Stephanie writes, wellness class is the best. And Stephanie is referring to something that we've invented at Ohio Health. It's an MS wellness program. She's been involved. She's doing a really good job of it. And so I'll maybe do a video on that where I explain to you sort of what we're doing with MS wellness. All right. So looking at a couple other questions here. I've got a couple other words of the year. I have Robin, determined, empowerment, hope. These are awesome words. Fearless. I like the word fearless. That is a good word of the year. I've got warrior, MS warrior. I talk about being an MS warrior a lot. And what does it mean to be an MS warrior? It means that you get up and you fight every day. You fight against this disease to not allow it to make decisions for you. You fight to choose to do what you want in your life and not allow MS to make that choice for you. And you can be an MS warrior in a wheelchair. You can be an MS warrior in a gurney. You can be an MS warrior at the CEO table, killing it. And I want everyone listening to be an MS warrior. And you don't need to steal your son's Viking hat to be an MS warrior. But if you do, it looks way cooler. At least I think. All right, what else do we have going on here? But Kim, the MS warrior, I'm loving that. Steadfast, spirit, strong, faith, perseverance, hopeful, courage. These are awesome words. I want you in 2019 to pick a word of the year. I want you to write it down. I want you to think about it. I want you to look at it every day. And I want you to ask yourself, what am I doing today to realize that word? If my word is healthy, what am I doing to be healthy? If my word is no surrender, what am I doing to make sure that I don't surrender? If my word is courage, how am I being courageous today? If my word is acceptance, what is it that I am going to accept today? This is a call to action for the people listening. For the people listening to adopt a word of the year, which is going to drive them through 2019 and make 2019 freaking awesome. All right, so we are about to wrap up. It is almost 8 o'clock, and I promised my family that I would only do this for 1 hour. Stuart Schlossman down in sunny Florida writes, what do you advise for those over 65 whose insurance companies find that they're so stable, the time has come to come off medicine? Now, Stuart, I have put out a YouTube video discussing whether or not we should stop disease-modifying therapy in those over 60. Here you point out 65. And my answer is that's insane and you should not stop medicine. Maybe the reason that that 65-year-old is doing really well is because they're on medicine. And so I think that's insane. Now, I predict the future of MS therapeutics is de-escalation. De-escalation. I did a video on this just last week. And de-escalation means you start off early on the diagnosis with the most heavy-hitting drug that you have. And then later on down the line, you de-escalate. And so it may be very reasonable to de-escalate therapy at age 65. Maybe you go from a high efficacy drug that has some side effects that are to something that is actually a lower efficacy, but we're still treating you and the side effect profile is better. And so my opinion is that we should not stop. Think about it. I have depression and I take a medicine for that and it helps me a whole bunch. When should I stop my antidepressant? Should I say, well, you know, I haven't been depressed for a long time and now I'm X age, so I don't need to be on that medicine? That's nonsense. I have high cholesterol. Thanks, Dad. I love having high cholesterol. And so I take a pill once a day that lowers my cholesterol. So should I stop at age 65 because what doesn't matter? No, on the contrary, my risk for stroke doesn't disappear. My risk for heart attack doesn't disappear. And so I need to keep on keeping on with that medicine. If you have MS, you have an autoreactive process where your immune system is revved up and it's going way too fast. And yes, it gets quieter as you get older, but it's still there. And so I don't think that we should stop therapy. I really don't. I think that maybe de-escalation is okay. Maybe, maybe not. All right, I'm going to take one more YouTube question and then I'm going to wrap this up. And so let's take a quick look and see what's the deal with another YouTube question. I've got Lainey saying, P.S. thank your wife and kids. Have a happy new year. So thank you to my wife and kids for letting me do this tonight. I really appreciate it. All right, party on Viking. I'm looking for one more question that I can answer. And so let me find a question. And if I haven't gotten to your question, please include it in the comments. I'm going to look through the comments. And this will be fodder for me to consider for videos in the future. All right, I'm still looking for a question. So Susan writes, if you've been taking a 1-year break and now realize that because of that, you should go back on, do you recommend Copaxone or to go on Ocrevus? Walking trouble for years, getting worse. Okay, so we live real lives. This is not make-believe land. This is not Ken and Barbie world. This is the real deal. I saw a patient today in clinic who I love. She's awesome. She's a really cool woman. I really, really enjoy interacting with her, and I've enjoyed over the years taking care of her. And I saw her in clinic today, and I looked at her last clinic note, and it was December 27th, 2017. I said, darling, have you not been here for a year? And she said, no, I haven't been here for a year. And I said, well, when did you last take a therapy? And it was 5 months ago. And I said, when was your last MRI? And it was a year ago. But you know what? Who cares? She was in my office today and we restarted. We ordered new MRIs. We got her on a new medicine and it's a new day. It's a new year. And so it's never, ever too late. Now, which medicine is something that I can't answer for you. And that's something that you have to work with your MS provider to figure out the right drug for you at that time. But there is never too late. So you took a year off. So you took 10 years off. Let's jump back in. Let's jump back in. All right, it's time to wrap things up. My name is Aaron Boster, and thank you for joining me tonight. Thank you for learning about MS with me. Thank you for helping me bring in the new year. We are a community, and one of the things that I love more than anything about social media is the fact that I can reach out across the globe and talk to people in Switzerland and talk to people in Florence and talk to people in London, England, and talk to people here in Ohio. And I can interact with them and I can share my thoughts and they can share their thoughts. And many of you know that I believe that in order to beat MS, we have to have a village. And I want your village to be global. I want it to be the biggest village that you could possibly have. Because it's my belief that the more village members that you have, the stronger you are. And you can have village members online. I have village members online. So this is Aaron Boster wishing health and happiness to you and yours. We have MS is a hashtag that I've used for quite some time. And I think it's appropriate tonight. And I'm going to log off and I'm going to finish this grog. I may have another grog. And I'm going to hang out with my family and reign in the new year. I love you guys. Thank you very, very much for being there for me. And I want you to know that I'm here for you. And with that, I wish you the very best of the very end of 2018. And I look forward to more interactions with all of you in 2019. If you haven't had a chance to check out my YouTube channel or my Facebook page or my Twitter, do that. And until my next video or until the next time that we have an opportunity to chit chat, take care. It's not ending.